Hi everyone, my name is Sara Lojo. I'm an interventional radiologist based in Spain.
IR has evolved enormously over the past decades, offering highly sophisticated minimal invasive treatment for a wide range of complex conditions with excellent technical outcomes. But this technical evolution has not always been a parallel evolution in how IR is integrated into patient care and hospital structures. In many institutions, IR are still perceived as procedural expert rather than clinicians responsible for the patient throughout the entire pathway. This limits our involvement in clinical decision making, reduces our visibility within multidisciplinary teams, and at times affect how patients understand our role. This gap between what IR can do technically and how it's positioned clinically was the main motivation behind this paper. What we wanted was to step back and reflect on IR as a clinical specialty. We looked at aspects that are often underrepresented in the literature but are central to daily practice, as patient management before and after procedure, communication, integration into multidisciplinary teams, training, leadership, and the long-term sustainability of the specialty. What this paper adds to the field is a structured framework to think about IR beyond the procedure itself. It reinforces the idea that technical excellence, while essential, is not sufficient on its own. Clinical responsibility, organizational integration, and human engagement are equally important if IR is to continue growing in a meaningful and sustainable way in the line with the vision promoted by CVIR. For IRs, the paper highlights that participation in outpatient clinics, multidisciplinary meetings, and follow-up should not be viewed as an added burden, but as a core component of clinical care. These activities strengthen decision-making, reinforce the clinical identity of IR, and are often associated with a greater professional satisfaction. The paper also underscores the importance of non-technical skills such as communication, teamwork, and leadership, which are essential for the credibility of the specialty and effective collaboration within complex healthcare systems. For other specialties, the message is clear. IR is not a simple procedural service, but a clinical partner that contributes to treatment strategy, reduce invasiveness, and improve efficiency. This model promotes collaboration rather than competition, supporting more coherent care pathways and stronger interspecialty relationships for the benefit of the patient and the healthcare system. From the patient's perspective, these changes have clear implications. When IRs are involved early in decision-making process, communicate directly with patients, and remain engaged after the procedure, care becomes more coherent and less fragmented. Patients better understand their options, feel more confident in their decisions, and experience greater continuity of care, particularly in complex or chronic conditions. Minimal invasive treatments already reduce physical burden, and this paper highlights that IR can also reduce emotional and organizational burden. Clear communication, continuity, and defined clinical responsibility help reduce anxiety and improve the overall patient's experience. Ultimately, this work argues for a more humanized model of IR, where technological excellence is combined with clinical presence and patient-centered care.